Good afternoon, Asim sir.
Good afternoon, Pratima.
सर वीडियो अल्टीमेटली कौन सा वाला प्ले करना है सर? जो ड्राइव में भेजा है क्या वो शेयर करना है क्या सर?
So you have edited or not?
बैकग्राउंड नॉइस हटाया था सर, बाकी और कुछ एडिट नहीं किया है, तो इट कैन एक्चुअली प्ले एंड यू कैन एक्सप्लेन उसमें क्या हो रहा है। मैं साउंड म्यूट कर सकती हूँ, थोड़ा बैकग्राउंड में अलार्म्स आ रहे थे।
You just decide which is better, then you can.
हाँ दिखा सकते हैं, मैंने एडिट कल वाला करवाया था, आज सुबह वाला तो नहीं करवाया था।
हाँ ठीक है, एडिट वाला कर दीजिए, कोई बात ठीक है।
कौन सा विदाउट साउंड वाला दिखा दो क्या?
Without sound, yeah, then Paruldi will describe or baby will describe what they are doing. That's better. I think the sound is not good. Okay.
बैकग्राउंड नॉइस आ रहा है ना, तो इसीलिए मैं आज सुबह वाला प्ले कर देती हूँ, उसमें हम लोग वो म्यूट कर देंगे वीडियो, तो आप उसको एक्सप्लेन कर दीजिए।
ठीक है ठीक है ठीक है।
Hello, good afternoon. Am I audible? Good afternoon. Hello, hello.
Yes sir, you are audible sir. Shashikant sir, you are audible. If you want to check your slides, you can check that sir.
Can you hear me?
Yes, sir. Yes, sir. Tejas, we can hear you. Yeah. You'll be playing the video only now, sir?
Yeah, that one suctioning video we just made it for the last time in ventilation workshop. So we'll play it now. Okay.
So Asim sir's का भी video है. I will share it. And I will mute the video and sir will actually explain or Parul ma'am can explain.
Share the screen and let it to play.
The screen and
Just enable this
which
here.
Achha,
That one, this one.
optimize the video.
Just double click on, otherwise you can. Just double click it here. Otherwise,
Not this, no?
just enter screen. Just to open the PDF.
Here is playing now. Playing now. Hello?
Yeah, explaining it's audible also. Yes. You will be explaining now with the background.
Percy will be explaining it because it is in the real life scenario it is there.
Yeah.
We will be
Same
explaining
is
it.
with Asim sir's video also, sir. Yeah. And the video will be playing and the team will be explaining.
Yes. With me, I see.
Stop. It is in the live also. Live.
Template you have for the first template.
Hello, Prem ma'am and Parul ma'am. Hello.
Yeah.
Good afternoon. Good afternoon.
Good afternoon.
We both of us we are joining from one desktop. Okay.
Okay, so
তুমি বসো তুমি বসো তুমি আমাকে একটু আমি এর উপরে বসবো
Dr. Prashant is also ready. He called up. He said that around 12:40 or so he will directly and then live demo he will do, sir, from the unit. So you can introduce like that.
to participate.
Hi Mayank, what's the situation? Net and all is ready. Staff, Mayank.
Good afternoon, ma'am. Yeah, we are ready, ma'am.
Okay, ठीक है. Intros followed by Asim sir's video, then Prashant sir's, and then yours, Mayank. Okay.
So it would be a live demonstration, right, ma'am?
ठीक
Okay,
है.
we are ready for the live demonstration.
You don't have the video, na? You have live only, na? It's a small
Yeah,
one.
we are demonstrating live.
Okay.
Let us know when to go to work. Preterm madam and Paralaka is at the same place, no? Padma, needed in coming. Any update on this?
Giving status.
Okay, it's 12:30. Teju sir, I think you can take over and start the introduction, sir.
Padma, can you? Good afternoon, everyone. Hope I'm audible, Padma. Is it okay?
Yes, you're audible, sir.
Yeah.
Distant, but it is audible.
What is? Okay. Good afternoon, everyone. So we are coming to the end of week 8 of our preterm care course at the nurses. This week we had discussion on reducing systemic infections. We have gone through a lot of webinars and many asks, and there were many polls that have been conducted by our own faculty. And thank you for all for interacting very well. So we have today all of our faculty with us who have been contributing to you in this week. So we have, I think they can just share this video and then let's stop sharing this and then we'll project the videos so that it will be easy. So that all of them can see all the videos. Can I request all the faculty members to share their video? Okay. Baby Mandal madam and others.
Sir, I'm not sure if I can hear you very well, sir.
Yeah, I think. Okay, I'll just start introducing. We have Dr. Asim Malik sir, who is a professor and from NRS Medical College, Kolkata, Bengal. And from his team, we have also Baby Mandal Madam and Parul Datta, who are from the nursing department from the same medical college. And we also have Dr. Shashikant Dharathar, who is from associate professor at Faridkot Medical College, and he is also unit head from there, Punjab. We also have joined now Dr. Anita Yadav. Anita Yadav is associate professor at Safdarjung Medical College, New Delhi. From this, we have Dr. Prashanta, who will be joining with us. You can see now Dr. Baby Mandal Madam and also that one. Mayank Kalide. Mayank is assistant professor at AIMS.
Yes.
Yeah. Okay. AIMS Jodhpur. That needed to be joining from Jodhpur shortly, if possible. And then we also have Jyoti Pogot. What is it? She's not. Yeah, she is joined. Thank you very much. You can unmute me. Thank you very much. She is the nursing faculty from Lemon Medical College, Ambala, Haryana. We also have Lata Vegetation, Principal Nursing College from All India Institute of Medical Sciences. Lata Madam, can you just, is there? She's coming. Yeah, she will be joining with us. Neeraj and Lata madam might be joining with us. So, we will start off after this. I think I will hand over the mic to Dr. Fatima. She will just brief us about the today's session.
Yeah, thank you, Tejo sir. I hope I am audible.
Yeah, you're right. You're right.
Members and our nursing colleagues for making it so interactive this week, and I think this was the highest interactive phase which we had in this week 8. And asepsis, as we all know, the sepsis is the biggest killer in NICU. No matter how much we work hard, we have seen kids deteriorating, neonates deteriorating within a matter of hours. So it is very, very important. No matter how many times we stress, I think it will be very less still. Each time we need to, we get to learn so many new things. So today we will be predominantly having live demonstrations from different units across India. And we are thankful to the faculty and their nursing staff for cooperating with us and for participating in the live session today. I hand over to Dr. Anita to kindly introduce the program, and then one by one we can move to the videos, to the live demos. Yeah, thank you. Dr. Anita. Are you able to unmute, Anita?
She's there.
She's there. I think
Yeah, she came. No, it unmute. Yeah, now she is unmuted.
Am I audible?
Yes, yes.
Yes.
Okay, so today our live demos will be by Dr. Asim Malik, baby model, and Parul Datta will be conducting live demo on delivery room preparation. Dr. Prashant will do the live demo on Class B checklist while insertion and also how to maintain the line on the mannequin. Then we will have suction in a ventilated neonate. The video will be by Ms. Percy. And Dr. Mayank will do the live demo of cleaning and resuscitation equipment. So those will be the demos for today.
And it will be followed by a summary of the week by Dr. Shashikant. Yeah. And then a panel discussion also is there. Yeah. So, Dr. Tejo, should we move ahead with the first video? Is the team ready?
Dr. Asim's team can start.
Yeah. We will be playing the video from your unit. So you can, I'll mute the video and you can actually explain what is happening. The first demo is on how to receive a baby who is coming to the NICU, whether it is an outborn baby or inborn baby coming from the delivery room. First of all, communication is very important. The emergency team or the delivery room area team has to communicate to the NICU team to keep the bed ready. So what are the components in keeping the bed ready? It should not be a hurried reception, and in the process, we actually may introduce sepsis to the baby who may be just coming with prematurity or just asphyxia, moderate asphyxia. If we are not careful while receiving the baby, then it's an important crucial step of a breach of asepsis. So I'll be just playing the mute video, and please explain it side by side. Is it okay, the team, the West Bengal team? Asim, sir?
Yes, yes, madam, it is okay. Okay, we will explain. We will explain.
You also keep unmuted so that it will be easy for you.
So this is the team, one doctor and two nursing staff. We are here to receive and we are here to demonstrate the receiving of a newborn baby, especially the preterm newborn baby from the delivery room, and the baby is may have some problem. Anticipating that problem, we are preparing ourselves, and all aseptic techniques should be followed for the preparation. So doctor is explaining, Dr. Mollik, and myself, Parulato, and baby Mondol, three of us.
Okay, so the problem is that it is a baby of 1.4 kg, 33 weeks. From labor room, they say that the baby may need respiratory support. So our video will show that how to prepare aseptically for receiving the baby in a warmer, and then if the baby needs CPAP, then how we will prepare aseptic way the instrument of CPAP, then their accessories. So Paruldi will demonstrate what is the step of asepsis and baby mondal. Now they see that the baby mondal showing the 6 steps of hand washing.
So 6 steps of hand washing using chlorhexidine based liquid soap and following the 2 minutes and 6 steps including up to wrist and elbow, because when we are handling the baby, only the WHO hand washing steps up to wrist is not always possible.
So where is the slide?
So please.
Yeah.
Is there any problem regarding video?
Can you keep the video?
Please make it okay. Okay. So after hand washing and everything should be prepared around the radiant warmer. So radiant warmer, all the autoclave sheet we'll use, and before that radiant warmer should be cleaned. Body of the radiant warmer is cleaned with 2% bacillocid, and the panel is cleaned with soap and water, and bassinet is cleaned with Bacillol 25. All the seats are autoclave seats, bed sheets are sprayed, and then a nesting is prepared, and one extra seat is there for covering the baby and swaddling the baby. Baby's napkin, and so for the shoulder roll, one shoulder roll prepared, and that was all placed under the radiant warmer to pre-warm that, to prevent hypothermia of the preterm neonates when we are receiving that neonate. So, and along with the preparation of radiant warmer, it was the before preparing the bed or bassinet, the radiant warmer, it was actually previously it was demonstrated, so it was cut and added. So all the parts of the radiant warmer, including the radiant warmer and parabolic reflector, all the rods, all are cleaned with 2% bacillocid, considering all the corners, because if there is any dust that can spread and over the baby, and that can spread the microorganism. And even in the bassinet, everything, all layers should be removed and all corners should be disinfected with the Bacillol 25. And body of the radiant warmer is disinfected with 2% bacillocid. But after discharge or death or after 7 days, the body of the radiant warmer and bassinet, everything should be washed thoroughly with soap and water. Here Bacillol 25 is used to for the concurrent disinfection, but for terminal disinfection, we are cleaning whole unit with soap and water and then allow it to dry, and then we after drying, we disinfect with 2% bacillocid as terminal disinfection. But for concurrent disinfection, body of the radiant warmer is disinfected with, and surrounding is disinfected with 2% bacillocid solution, and bassinet is disinfected with Bacillol. Both are showing that is in baby Mandal's hand. And other than that,
Paruldi, if the bacillol is not available, then what can be the alternate solution?
Whatever disinfectant is available, even now in COVID situation, we can use 0.5% hypochlorite solution also we can use. Even if nothing is available, we can clean thoroughly with soap, and that will help to clean, remove the organism. And surroundings, all the walls are also cleaned with 2% bacillocid, and the radiant, beside the radiant warmer, the suction apparatus, oxygen source, everything should be ready. And for that, for CPAP machine is ready. If the baby is preterm, baby may have respiratory distress. So that's why CPAP machine is kept ready, and all the circuits of the CPAP machine in this unit, it is sterilized using ETO, ethylene oxide sterilization is done after thorough cleaning with soap and water and drying and then packing. There is a good system with the help of the support staffs. We are practicing the sterilization of all the CPAP circuit systems, and we are maintaining always we are maintaining the non-touch techniques to prevent the contamination of care articles, and we are using disposables. Whatever disposables we are using that are single use, and we used to dispose that as following the biomedical waste management rule. We have not shown that things. And for when we receive the baby, before that we clean the radiant warmer probe with 70% isopropyl alcohol that is available in our unit, and the probe of the pulse oximeter also disinfected. Before use, we used to disinfect it with 70% isopropyl alcohol that is available. And at the bedside, we used to, and on the tray, we used to arrange all the care articles, including isopropyl alcohol, povidone iodine, and a thermometer, and a small knife dish containing the sterile cotton swab. The probe is disinfected with the using the baby. Here, baby is handed over to the staff nurse, and baby is taken from the delivery room and handed over. Sorry, not staff nurse. Baby Mondal is here. She is demonstrating. The nursing staff is receiving the baby under that time the warmer was in manual mode, and already probe was cleaned. That probe was attached on the right upper abdomen, or mainly right hypochondriac region, and from manual mode to the warmer was set in the servo control mode, and the set temperature was 36.5. We all know that hypothermia also induce can induce the infections. And even I have used the hand rub with the following 6 steps in 20 or to 30 seconds before handling any things or any items around the baby care area. So now the baby care, the pulse oximeter probe is attached before the baby was placed, and the thermistor probe was attached on right upper abdomen, and the pulse oximeter probe that was disinfected or with the use of antiseptic 70% alcohol. And after disinfection of the pulse oximeter probe, then pulse oximeter is applied on the right arm, right forearm or hand, right hand or right wrist to assess the preductal saturation. It is most important after receiving the baby and positioning the baby. So we have maintained the warmth under radiant warmer, we have positioned, and the secretions were not there, so suctioning was not done. Then pulse oximeter was applied, and we have recorded the saturation. And if the saturation is less than, the baby was not required at that time. If the baby saturation is less than 90%, we have to administer oxygen. And if the baby is having indications for CPAP therapy, so everything is ready. So CPAP machine is there and ready with all sterilized, ETO sterilized CPAP circuit. And these are the sterilization of CPAP circuit was done after immersing in the soap and water, then cleaning thoroughly under running water. This is going on. The cleaning of the CPAP circuit is going on with gloved finger, and then thoroughly washing in water to remove all the soap, to clean it properly. Then all the parts, including the humidifier parts, this is that is cleaning under running water, first with soap and water, then thoroughly removing the soap before allowing to dry, and then packing for, these are all allowing to dry. Drying of the tubes, and we usually place the tube in a longitudinal way so that all the water will remove thoroughly. And then this is the packing before ETO. The special machines are there with in this unit, so that's why the ETO sterilization is used for the all respiratory support. These are all articles used for items used for the CPAP. These are all disposable items. And as these all the disposable single-use items and ETO sterilized CPAP circuits are used, so there is less chance of there is very less respiratory infections of the preterm neonates. Even when the babies are placed under ventilator, they are also ventilated associated pneumonia is very less. Here the infection rate is less than 5%. Yesterday, out of 40 babies, and only 2 babies I think was on antibiotic. When we have recorded, we have checked the records. So rate of use of antibiotic is very less because we are practicing all meticulous disinfection and sterilization method, housekeeping, equipment contamination, decontamination, and sterilization. All infection control measures are maintained along with the present situation, COVID appropriate behavior, and distance between 2 radiant warmer is maintained more than 6 feet, especially in the special preterm neonates. So we are trying all these to reduce the incidence of infections in our unit. I hope this video will help. Though video quality is not good, but I think we have tried to explain what we have practicing in our unit. Thank you. Dr. Mollik, you like to add anything? Or baby, Dr. Mollik, you can unmute yourself. Baby, baby Mondal.
You see that how meticulously the aseptic procedure performed in the SNSU of a Institute of Epidemiology, Kolkata. So that's why their infection rate is very low. You see, they are already, Parul just told that out of 40, there are only 2 baby gets antibiotic, and they are all of the non-invasive methods they are using that thing. So that's why the neonatal mortality rate also there is very less. Only thing they ask baby that how the compliance of hand washing you are maintaining in your unit. Compliance of hand washing. Is there any procedure? Yeah, you do that. The compliance of hand washing.
Sir, in our unit, when before entering or before leaving, we used 2 minutes of hand washing. Maintain WHO 2 minutes of hand washing, and in any time there was in every baby there was a hand rub, and before touching or any patient we maintain 5 moments of hand hygiene. And when new mothers come in our unit, then first time after changing her dress, or then we teach mother how to hand wash and how to rub her hands. And even not only our staff, the old mother, those who are here in many time more than 10 to 50 days, then these mothers also teach new mothers how to clean her or how to wash her hands and how she use her hand rub. So it is we also maintain it is meticulously. So for that reason also in our unit there is the infection chance is very low.
One point here, another point I like to highlight, there is a peer group supervision. If any nursing staff or doctors are not doing hand wash properly, then peer group, even mothers also noticed and complained that they are not, new staffs are not doing hand washing. So there is cross-checking of techniques of hand washing and timings of hand washing. And in the hand washing area, there one watch is there to follow that, whether 2 minutes hand washing is following or not.
Okay, so lastly, I am mentioning that
I mentioned one thing, sir. It is our mothers. They are very conscious. If any mother, they change their night dress.
Okay. You see that at the time.
Hand washing charts also available everywhere.
Okay, so the main thing is that what we are following in our state is that the hand washing compliance is bestly observed if there is a direct supervision by nursing staff. One of the nursing staff is staying there for see that whether the professor or teacher or any other or nursing staff group D, they are doing their hand wash or not for 2 minutes. Okay, so thank you for this video and nicely demonstration. Over to Tejo.
Thank you very much, sir, for reinforcing and playing the video. So the mother is always, she will be the one person who can even guide the nurses how to do the hand wash once you make her learn about the hand wash properly. And
Tenu sir, your voice is not clear.
What slide there is?
Sir, you can use earphone. You can use earphone.
1 second. 1 second. Okay, I will use a little more voice. So the thing is that if you train the mother about hand washing and aseptic techniques, I think she will be the best person and best teacher for all the incoming mothers and also the nursing staff and doctors who are there. So for all of them, I think she will be the one person who can easily monitor and track. So thank you for reinforcing it, sir. That's what we can do. Next will be by Dr. Prashanta. Yeah, Dr. Prashanta, are you ready? From Safdarjung Hospital.
Yes, sir.
There's about asepsis during the.
Yes, sir. Yes, sir. So, thank you, sir. I'm with my senior staff nurse.
Sure. 1 second, Pratima, can you pin the Prashanta's video so that
I have pinned, sir. I think it will be visible on YouTube as full screen only.
Okay.
I will ask Anita also to pin it. Yeah.
Yeah, am I audible, ma'am? Am I audible?
Yeah, you are audible. You are clearly audible.
Yeah. So I'm Prashant here from St. John's, Bangalore. So we have our staff nurse, Sister Deepa, who will be taking us through the insertion checklist as well as the maintenance checklist of central line. No, just a moment. Is it okay? Yeah. Yes, ask him if you're audible.
Hello, good afternoon.
Am I audible?
Am I audible? Hello.
Yes, you're audible.
Yes, you are audible.
Good afternoon.
Yes, you are audible. Good afternoon. You are audible.
Yes, we are going to show a small demonstration of checklist for insertion of central lines. Okay, first what and all we are going to see the central line checklist means we have to see whether date of the patient name and HIPOP number we have to write. In that we'll be seeing the personal preparation and other critical steps and post line insertion. So this is a daily basis. Means whenever we will be inserting the central line, we'll be seeing this checklist monitoring. And personal, we have to see whether the fellow present. Yes, we have a doctor already is a scrubber and is present for the inserting the UVC, and a senior staff nurse, one who is going to monitor. I am there, and the one more staff nurse for assistant, she's there. And next we'll be seeing the preparation. So I'll be putting the tick in all this one whether it is present or not. Yes. Next is the preparation. What in the preparation we have to do means we have to see the patient name, ID number noted, already we have done. Site of procedure noted, already doctor is done. And warmer preparation as per the requirement done. Yes, we have already kept in the manual mode. And measurement needed, that is umbilical line length done or not, already is done and kept. And next we have to see the make sure all needed parts of the kit is present, that is the central line umbilical site, whether all the instrument is there, whether the forceps and UVC catheter with the flush and all the forceps is there with the 2 bowels with the chlorhexidine and NaCl flush whether is present, and drape is present. Everything we are checking whether it is present or not. If it is present, we have to put the tick. Next, getting ready. Already cap and mask is put on. Our doctor is already put on cap and socks. Is already washed with soap and done. And sterilium is applied and the gown put on. And next he will be doing the site preparation. How he is going to do site preparation? We have to see. With the chlorhexidine, preparation done 3 times. We have to see whether it's done or not. If it's done 1 or 2 times and he stopped, we have to remind the doctor whether it's the 3rd time, please do it.
Prashant, you can switch off the light there so that the clarity will be more.
Light off. Yes, sir.
Yeah, now it is clear.
Yes, sir. So he has done already chlorhexidine preparation done 3 times, and line preparation he has to put the identify the right line as already has identified and kept, and flush with epilogue done. That is the UVC catheter is already flushed with the epilogue and kept, and drape the site with the drape. Next we'll be seeing other critical steps like he has to do in the single attempt. Whether he is inserting with the single attempt, we have to see. So next, whether with the insertion with the forceps is done or not, we have to see. Yes, he has done with the forceps. And he has to see hemostasis achieved with the pressure. Like any bleeding is there, he has to give the pressure. Okay, after show hemostasis to the staff nurse in charge, one who is present. And fixing with the sterile pad completely by the same person, like one who is inserting only, he has to complete the fluid, IV fluid connecting and all, he only has to do with the sterile technique. And flush with epilogue is done, and sterile Q site to be fixed by the same person.
Okay. Yeah.
So after that, we have what and all done, we'll be putting the tick, and if it's not done, we'll be putting the into. And post line insertion, what and all we have to see means after insertion whether it can be confirmed with the echo or chest X-ray can be done. After this, we have to put the label, date of insertion, and fixed at what centimeter. It should be labeled in the UVC site.
Next. Not this. Okay.
So next we'll be seeing the central line card. This card will be putting in the baby side. So after insertion, like per day, how many times will be breaking this line? We have to put like which is the date we have inserted UVC, and day of line like day 1, yes or no, needed or not. And if the conductor is put, he'll be putting the sign. Next time it is a fluid changing. Next person if breaking means they'll put the signature. So every day it is monitored, and how many times it is opened UVC. So that will be monitoring the central line card. So final, when the UVC is removed, this card will be going to the baby's file and will be auditing how many times it is opened.
So this will be beside the beside the warmer.
This will be attached to the baby's warmer side, so that every day will be checking this one how many times it is opened. Next we'll be seeing the central line maintenance card. This is the card. This is done. This is done suddenly when we'll be they'll be doing central line like fluid connecting or injection giving. Suddenly we'll be going and monitoring without informing them, like whether auditing the central line, and we'll be seeing the whether they have done hand hygiene like health worker, and with the gloves they have put, or central line circuit break in how many hours we'll be checking, and scrub the hub how many times done, so that we can see how many times they are doing now.
We are demonstrating the scrub the hub.
So here we are demonstrating how we are doing the scrub the hub. Scrub the hub we have to do 15 seconds. That is, they have to count 1, 2, 3 like that. They have to count for 15 seconds.
5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15.
So after the 15 seconds, we have to leave the line for 30 seconds. Then only we have to give any injection or water. With the chlorhexidine only, they have to do the scrub the hub. We have to see whether with the chlorhexidine only they have done. And there should be 2% for the any injection in the central line. That is, one who is giving and one who is assisting. So 2 members should be there whenever we'll be breaking the central line. And single port, that is the Q site, which is the doctor already shown. Q site should be present. With that only scrub the hub should be done. And all the procedures should be done aseptic manner. So where any wrong things they are doing means then and there we have to correct those who done. We have to correct then and there so that we'll be not repeating next time. And overall, whether it is done or not, we'll be seeing whether yes or not. So this is the central line maintenance card.
Thank you, Sister Deepa, for this excellent demonstration. Is there anything which we need to do, sir?
Yeah, Prashant, I think it was very good video demonstration. From your team, I think because you people have already worked on the CLABSI infection rate QA also. In your experience and from your unit experience in that QA, what are the steps that you feel that in the aseptic precautions which will actually guide to reduce the CLABSI? What are the main bottlenecks?
So the most important thing which we thought was the overall infection rates, which has to come down. The most important thing would be the hand hygiene. So we usually look at the central line at two aspects. One is the insertion, and second one is the maintenance. So these are the two, I might say, the the chances where we give for the infection to creep in. For insertion, we have a CLABSI protocol where we define who is eligible to put central lines. So the person should have at least done an assisted 5 central lines. So that person will be eligible to pull central lines. And so when we do a central line insertion, as Sister Deepa just demonstrated, we always do with a checklist. So which will be the person, the sole job of one person who will make sure that all the steps are being carried at the insertion site, and we'll make sure that it is all the aseptic techniques have been followed. The second instance where there could be chances of CLABSI would be the maintenance, which we all know. The longer we keep, the more line breakages we have, more will be the chances of infection. So we have a system in place to make sure that we have the least possible circuit breakage, that is, opening up of central line. So that we audit every day that how many times the central line has been, opened up. The second thing would be to audit the number of days of central line. So we want to keep the central lines to as minimum days as possible. So every day we audit to see if the central line is really required for that day. So if it's not required, so the central line will be removed as soon as possible. The third thing is when we have to open the central line to give injections. So as Sister Deepa just demonstrated now, a strict precautions would be taken, because we know the portal of entry will be the hub of the central line. So we make sure that that it's a 2% job whenever we administer IV injections, and we do scrub the hub routinely, and there would be random auditing of the maintenance of CLABSI. So these are the few steps which we take to decrease the CLABSI in our unit, from which we have got good results. Coming to a second question about bottlenecks, I think the most important bottleneck is to make the nurses realize that that it is important. So as I said, we have ongoing QI which is going on. So we keep regularly. So based on the QI principles, we keep regularly updating our own audits. We keep updating our infection rates and display every month. And if there is any problems like increased CLABSI or something, we do root cause analysis to see where exactly was the breach. So the bottlenecks probably would be in this process is the addition of new staffs. So that is the turnover of the staffs. So we have a system in place to teach them. We have various simulation programs for the new entrants, and also sensitization of the senior staff nurses on a regular basis. So these are the solutions, sir.
Thank you, Prashant, for enlightening us about your good QI program that is going on, and also emphasizing about the display of the infection in your own unit, and that will give you more motivation and also caution you that when it is going up and down. So there are some questions from the chat box. One is that how many days we can keep the UVC?
So there is no There's no clear-cut answer to that. And as consensus, it should be between 5 to 7 days. That's the maximum. It all also depends on the CLABSI rates in your unit, own unit. If you have high CLABSI rate, I don't want to keep the central line, as long as 5 to 7 days, maybe less. So the lesser, better it is. So I don't think we have an answer. If at all I have to give an answer, 5 to 7 days is the maximum number of days.
Sure. For the UVC, it is for some people can go up to 10 to 14 days also if you don't have any other PICC line which is there.
Yes.
So if you are using a central venous line like a PICC line, so how many days you can use it for your nutrition or for management purpose?
So again, the answer would be as shortest length of time, but we know that some of our babies would require central lines for longer time. In our unit, we generally keep PICC line for at least 14 days. 14 days if there are no other complications.
So beyond 14 days, you will try to selectively change it if at all it requires?
So I don't think we have had any babies gone beyond that, sir. So maybe we would want to change it if there is any other problems.
Sure. So usually many of the babies, even they are born at 750 to 800 grams or this thing. If you have a good enteral nutrition policy, I think you'll be able to make it to full feeds by 10 to 12 days.
Yes. Exactly.
And don't keep the PICC line only for the giving antibiotics or any other infusion to the baby. That is one important that we need to remember. And try to get out of PICC line every day, as Prashant was telling us that we need to be checking every day that whether this child needs PICC line for one more day or this thing. So as a policy, many of our units now, once the child comes to 2/3 of the enteral nutrition, stop PICC line and then come out to peripheral line, because peripheral line has less chances to go into infection compared to PICC line. So these are the things I think has given you a lot of bundle approaches and other things. I think you can go through it once again. Thank you, Prashanta, for your team and enlightening us and also giving us the live demo. Okay.
Thank you, sir. Thank you, sir.
Pratima, shall we?
Yeah, sir. We request you now to please share the demo on suctioning, sir. Neeraj sir will be discussing in the panel discussion only, sir. Yeah.
Sure. Maybe we can, same topic, you can cover it. That's what we can say.
Yes, sir. You can take comment from sir after this video. Yes, sir. Yes.
Sure. I will be showing a suctioning live video which we have recently recorded. Sister Percy, who is our in charge nurse here, will be narrating what is the thing that is going on here. Okay. Yeah, Percy, over to you.
Good afternoon, everyone. Yeah, this is the baby who was ventilated. Now we are going for suctioning, and for suctioning, the main thing is we will start with the hand hygiene. Hand hygiene is the most important thing, and a team should be prepared. 2 members are necessary. And the third thing is things should be kept prior ready. Okay. Next, the indications for suction are any desaturations, bradycardia, visible secretions in the ET tube, absent.
As you see in this picture, there is a saturation which is going down.
Yeah.
So they started checking it in the tubes there.
Yes. And for all these indications, like if the baby is irritable, baby is not comfortable on the ventilator, baby is fighting on the ventilator, if the baby is having decreasing breath sounds. So all these indications are for suctioning a baby.
You can also see in this ventilator graphics, you can see here the secretions, some telltale signs are there on the flow time loop. So there are secretions which are there and both markings which are in the inspiratory and expiratory.
Coming to the procedure, the team is ready, 2 members are ready, and both has done their hand hygiene. Okay, then coming to after the hand hygiene, they'll be donning a sterile glove, and they'll be fixing the first person will be fixing the suction tube, and they'll be opening the suction tube at the hub corner and be fixing to the suction catheter. The suction pressure should be fixed at 80 to 100 mm of Hg. And coming to that, the suction pressure for a small baby should be slightly lower, and for a term baby, or if the baby is having thick secretions, then it should be a slightly higher. That means around 100 pressure. And important things that we have to be noticed is the tip or the key part which you are inserting into the ET tube. It should not be touched anywhere, or till introducing into the suction ET tube, it should not be exposed. As in ANTT techniques, as we are learning, this should be done. And before introducing, the measurement of the length of the suction catheter has to be done. Yeah, here we are showing oral suction followed by EP suction.
So it is getting discarded.
Yeah, it discarded into the, it has to be cut and discarded in the red bin.
So as you can see, 2 people are ready. And then
Measuring the length of the suction catheter. And before suction, we are increasing the pressure slightly 10% higher than the baby is getting, FiO2, than the baby is getting.
so just increase the FiO2 by 10% so that there will not be any desserts during the procedure.
Yeah, throughout the procedure, we'll be monitoring the baby's vitals.
So use the TPs if it is very smaller baby so that it can provide both the PAP and P to the baby, and there will be reliable pressures that we are delivering.
And possible source of infection will be if the suction catheter touches the bed linen. It should not be that done. And negative pressure should be applied only when the suction catheter is drawing down.
So first re-oxygenate the chair, then you are going inside to the desired length, and then you are coming.
Maximum duration of suction should be like around 5 to 6 seconds, not more than that. In order to avoid hypoxia to the baby, we are doing till 5 to 6 seconds.
So here again reconnecting to bag.
Protein saline installations are avoided. And if the baby is having like very much thick secretions, then a 0.1 to 2 ml of saline installation and giving few breaths of through the neopuff is advised. And after the suction, post-suction vitals are to be monitored.
Thank you.
Pre and post hand hygiene is required for the suction procedure.
So the main important thing that we should remember in suctioning is that we are directly exposing
suction catheter
into the lungs directly. So it is like doing a surgery. So we need to take all precautions that we take during the surgery in OT. Keep all aseptic non-touch techniques. Follow these things routinely. Okay. Next is we have any questions in the chat box on this?
Not on this particular topic, but fumigation, about fumigation, Atiya.
That will take the panel. Can we move on to Dr. Mayank's team to show the cleaning of the resuscitation equipment, and then we'll come back to the panel. Mayank, are you ready?
Yes, sir. Thank you, sir. So,
can you increase your volume a little?
Yeah, am I audible?
You're audible, but voice is a little low.
Little low?
Yeah. I don't know. You are using mic, sorry.
Earphones.
Is it okay now?
Still.
Dr. Mayank, try to take off your mask if possible.
That is also one thing. Second thing, go to audio settings. While displaying the microphone, remove it, automatically adjust the microphone and then keep it at the highest.
Okay, let me see.
That will help you a little. Ready, Mayank?
You can go ahead and give the feedback later, maybe. Yeah, you can go ahead and give the video. You show the video, Mayank.
No problem.
Is somebody there with you? Yeah, you are audible, but little, I mean, the voice is low. Still.
Is it okay now?
It's better.
I think Tejo, we can supplement. Let him present. We can supplement.
Yeah, sure. Let him present. We will supplement.
Okay. So
start up, Mike.
Good afternoon to one and all. I am Dr. Mayank, working as an assistant professor in the Department of Neonatology at AIMS Rishikesh. To begin with, I would like to thank Deorari sir and the NNF team for providing me this opportunity to be a part of this wonderful e-course for nurses. I would also like to thank Mr. Devi Lal, who is with me, our nursing staff from the unit, who has volunteered to be a part of this live demonstration. So as in this live demonstration, we'll be demonstrating the cleaning of resuscitation device, one of the most commonly used self-inflating bag with mask. So without any delay, I would hand over this virtual forum to Mr. Devi Lal for further demonstration. Over to you, Mr. Devi Lal.
Good afternoon to all. As you know, in this week we are discussing about how to reduce the systematic infection in neonates. Today I will perform how to cleaning and disinfection for self-inflating bag and mask. After hand hygiene and donning sterile gloves, first of all, self-empty bag is dismantled and put into the already pre-pumped detergent water.
So what is, yeah. So you can take over, or Percy can maybe explain. Oh yeah.
Yes, sir. Can you make it to, yeah.
So, we are dismantling each part of the bag and mask, and we'll putting all these parts in soap solution. So we have already prepared the soap solution and Cydex solution. So now we are dismantling each part. So this is the process of disinfection, which we do usually after use in a septic or in a sick neonate. So this is the first part.
And to keep in separate.
So what he's doing after cleaning in soap solution, each part is being kept in another separate tray before it will be rinsed under running water. Is it audible okay, Tejo sir, Pratima ma'am?
Now it is very clear, ma'am. Please go.
Okay. So we have ladle bags, self-inflating bags, and we have different sizes. The bigger ones for the term babies and 250 ml bags for the preterm babies. So this is a term bag.
After washing the detergent water, we are good for cleaning under running water. After cleaning under running water, all these parts are to keep on a separate external table.
So after cleaning in soap solution, we rinse under running water, and the parts are being kept on another sterile sheet.
So Mayank, is it to be done daily once, daily twice, or is it after each use? The whole entire process?
So the process of disinfection has to be practiced after each use in the patient. However, in emergency use, for example, in delivery rooms, where we do not have ample time, we might just use an alcohol-based swab to clean the inner and outer rim of the mask. So this is the process which has to be done after each use.
Yeah.
We are going to inside it for 30 minutes for disinfection and for sterilization 6 hours.
So the dipping in Sidex solution the duration would depend on the intent. So if you are intending to disinfect, we'll dip it for 30 minutes. However, if you want to sterilize, you will have to dip it for 6 hours. So now we are disinfecting. The duration would be 30 minutes. For the sake of demonstration, we'll be taking out the parts just now for the further processing.
After 6 hours, we are due for
So again, we'll take out each part.
After taking the record of the part, keep on a separate stand at sea table.
So each of these parts which are dipped in Sidex solution would be cleaned again under running water and would be kept on a dry sterile sheet. So all the parts are being collected together, and after drying, these parts would be assembled to make a functional self-inflating bag again. So he's rinsing all the parts under running water. So now all the parts have been placed on a sterile dry sheet. Now each part will be dried using a gauze pad. So for drying, we would require some more time because there would be some water droplets left inside the bag, would be left in the patient assembly or in the oxygen inlet part. So this part requires some more time so that each part is completely dried up before we reassemble the bag. Mr. Devilal is also is a part of the e-course. He's also participating. He's one of the participants.
Okay, great. Very nicely being demonstrated, Mayank. Do let us know about other equipment like laryngoscope and the other things also.
Okay.
Yeah.
For laryngoscope, we first separate the blade and the handle. The handle just needs to be wiped with a alcohol soap swab. The blade, if it has to be disinfected after removing the bulb, the light bulb, it can be again with the same process after washing in soap solution and putting it in Sidex. The same process has to be followed for disinfection. But if we have to use in emergency, again, we can clean the blade with a alcohol soap swab.
Yes.
These are once again assembled for patient bedside use.
So he's now assembling all the parts together. So this is the patient assembly side.
Yeah, and regarding the use of disposables and suction jars, etc., we should also take care that the key part is inside the sterile part and it is kept ready for the resuscitation, and the tip should not be hanging here and there, the suction catheter tip. And the suction jar should also be cleaned regularly, and the water inside that should also be changed if it, yeah. So these are all the precautions in the delivery room and during resuscitation, because the breach in any of these steps will actually lead to early onset sepsis, and we actually think that it is from vertical transmission, but this ultra early onset sepsis is also known. The breaches in asepsis in the delivery room during resuscitation. So it is very, very important what Dr. Mayank and Devilal are showing. The resuscitation equipment needs to be reassembled, the ambo bag, and then cleaned thoroughly. And Dr. Neeraj and Dr. Tejo, you would like to comment any experience of yours?
I think these are the things that we need to be careful while we are doing it. Even the oxygen flow meters also has to be changed. Water has to be changed every 24 hours. So that we need to look at it. And then use maximum disposables whenever it is possible. If it is not possible, then you can use the reusables with a good intent. That's what I can say. Especially the masks and other things which are close to the baby, they have to be cleaned very with all stringent mechanisms and aseptic precautions so that there will not be any sepsis outbreaks in the delivery room. And also, I think clean cloths and other things, there is no much emphasis. There definitely we have to follow it. All the 6 C's of delivery room that we need to follow. Yeah, Mayank, anything? Dr. Neeraj, you want to add anything?
Yes, sir. For the basically the disinfection of all the equipments is an integral part towards the process of reducing the infections. So especially during the resuscitation, when there's emergency situation, we often tend to forget some important steps of hand hygiene, or in fact when we are in emergency situation, to reuse the equipments. So like in fact for self-inflicting bag or laryngoscope, we often tend to reuse even without proper disinfection or proper cleaning. So these are the small steps, but would yield much better results if these small steps are not forgotten. So now Devilal has assembled the self-inflating bag. So this is it from our side, sir. Over to you, sir. Teju, sir.
Neeraj, you want to comment anything, Neeraj?
So I would like to highlight only one part, that these all measures which we take to clean these equipments are very simple measures. The problem in our systems is that there is only one person who is taking care of shifting of patients or busy with other duties. So we need to assign this duty to people who can actually do this job. Otherwise, one person is doing multitask, so this part gets missed out, which is a very crucial part. So we need to see in our own systems that what is lacking, because in some systems you'll find that even the supply of these simple solutions, glutaraldehyde, bacillocid, these simple solutions which we are getting is missing, or there is an irregular supply. So we need to fix that. We need to assign some person who can take care of this job. And third is that it is always a good idea to sit with your own people in your unit to see how they are actually doing the things. Because so many times we assume that the things are being done in a right way, but probably it's not their fault because no one has taught them in a very structured way. It is just by by just hearing here and there, they make their own notions and start doing the things. So I think these are very basic things, but if we take care of these things, then this is doable, and which is very crucial and very important. And never forget about the cleaning part of a labor room, because though you may be taking a lot of care in your ICUs, SNCUs, but the first chain of infection after the intra-uterine period is from the labor room. So make sure that these protocols are in place in your labor room also. That's it from my side.
Sure. Thank you, Dr. Neeraj, for emphasizing all the points. Mayank, your dry sheets are very colorful. Very good. Not routine green color sheets you are using. That's really good. Ashim sir, you wanted to add anything?
Yeah, you see that in our state we are enforced that every SNCU or NICU there should be one nursing staff should be assigned for the infection control, and that's why she will look after the hand wash and she will look at the infection measurement and cleaning of the every instrument and everything. So that's why it is more fruitful to us. Okay, so one nursing staff should be enforced for this infection control. That's my message.
Good. Thank you, sir. Thank you very much, sir, for emphasizing it. Pratima, shall we move on to FAQs and other things?
Yes, sir. We can move on to panel discussion, requesting everyone to please join into the panel discussion. We have some queries in the chat box also. So we can take those in the discussion, sir. Tejo, sir.
Yeah, I think this is there in the chat box also. Dr. Neeraj, you want to take these questions? Do you recommend routine fumigation in your NICU or?
So I think it's an interesting question. In fact, this was asked in the Telegram platform also. So I think understand that what fumigation does. Just give me 5 minutes. So what fumigation does and what is the role of fumigation? So see, remember that when we fumigate any area, whether you're talking of operation theaters, whether you're talking of SNCUs and ICUs, for the moment it clears whatever is in the air, whatever is on the surfaces. But remember that these surfaces gets contaminated very quickly. So ideally, the main emphasis should be on the surface decontamination by your routine measures rather than fumigation. So routine, so just to say in yes or no, there is no role of routine fumigation, but it has to be used in very specific situations. Situation number 1, if you are using your unit for the first time, it's a newly constructed hospital. Like I came 8 years back in Jodhpur, we started our new neonatal unit. The construction work has just finished. So that was a point when we used fumigation for the first time. Second is, if some recent civil work has been done in your unit in terms of plumbing or some construction or some repair, some electrical work, then it makes sense to do. And third is, if there is an epidemic, you have some baseline ongoing thing of infection rate in your unit, and then suddenly you find some organism which was not there, or suddenly the number of organisms which are being isolated have dramatically increased, then it means there is an epidemic of that. So on one hand, you need to find the source of that, and simultaneously you can go for fumigation just as a broad measure to take care of that. So apart from these 3 situations, there is no role of routine fumigation. I'm going to your second question, Dr. Teja. What are the few tips to keep routine disinfection? So I think for the routine disinfection, I think you have already emphasized by a lot of videos that how all these things we need to disinfect. I think if there's some specific, we can talk of. Over to you, Dr. Teja.
Yeah, wherever the water areas are there, that we need to take care of. Wherever the wetness is there, that we need to take care of very well. Otherwise, there will be more problems and there could be breakthrough infections in the routine disinfection that you do. So that is one thing. Dr. Shashikant, sir, are you there?
So Dr. Teja, just wanted to highlight one thing which is again often neglected. See, the role of routine soap and water cleaning is very important. Unfortunately, we spend so much money in these kind of solutions, which is actually required. But a simple soap and water cleaning is very important. But because the ICUs are usually running full, there are a lot of gadgets, it becomes difficult to clean thoroughly with soap and water. So if you can devise some plan in your units, maybe twice, once in 2 weeks or once in a month, that will be great. To clean the floor, apart from the routine mopping measures of your floor as well as walls. So if you can create that kind of mechanism in unit, that will be great.
Sure. I think that's good idea, Neeraj. Very good idea. There is now COVID outbreak which is going on. So there are a lot of queries for the nurses when a COVID patient got admitted and then got discharged or has died inside the unit. What are the precautions that we need to take? Pratima or Dr. Shashikant, sir, both of you, because you have dealt with a lot of cases. Pratima?
Yes, sir. Yes, sir. Regarding COVID-19, I think there are specific guidelines for each step, like in the delivery room, post-delivery room, and there are certain guidelines for each area, like in the emergency and triage area, what should be the precautions and what should be the type of protective equipment which you should be wearing, which type of gloves, if at all, you should be wearing, mask, which type you should be. I like to emphasize on 2 or 3 things as per the NNF guidelines. There are 2 or 3 things. There should be minimum number of people who should be going inside to attend the delivery for a for a newborn being born to a COVID positive mother. And I hope I'm audible. My internet is showing a little instability. Dr. Teju, am I audible?
Now better, Pratima. No issue.
Okay, I have switched off my video. Yeah. So 2 or 3 things which I needed to emphasize was minimum people should be entering the delivery room. One team should be waiting outside. The team which is going inside should be wearing all the protective equipment, and they should be with all the precautions, including double mask. And the handling of the ambo bag should be, with 2 persons should be handling, 2-hand technique. The mask should be fit with the, tightly, so that aerosol generation is minimized, and other person should be doing the bag. This was one picture which was there in the delivery room precautions. And what was the other questions? Cleaning of the unit after the patient death or discharge. Yes. So that remains, that remains actually what we are doing in our COVID thing is, as per the guidelines, every 2 hours, even if the patient is there alive and sick patients are there, and patient has not been discharged, still we are housekeeping is being done too early in the COVID block, in the COVID positive block, where the newborns are there in the COVID positive area. And of course, after the death and the discharge, the whole warmer is taken out, and the mattress and all, it is removed. And as per the hospital infection policy, whatever disinfectants are there, mostly it is quaternary ammonium compounds which is provided. In our particular hospital, it's L-Guard, so it can be different in the different hospitals. We are using that only to clean the surfaces, plus soap and water, thorough cleaning after taking out the warmer outside. And of course, with the precautions, the health personnel should be taking all the precautions, and again wearing the PPE, complete PPE, while you are cleaning the warmer after the death of a COVID positive newborn. Although we haven't seen any, unstable and very sick COVID positive newborns yet, but we have SOPs for that. And this is the SOP which we follow. Even after discharge of a COVID positive neonate, we follow the same thing. The bed and the linen obviously we send it for autoclaving and cleaning properly. And the resuscitation equipment, circuits are disposable. And we have ETO, so the ambu bags and all the equipments which have been used for the baby, that are being sent for thorough sterilization. So these are COVID specific precautions which we are taking. Tejo, sir.
Yeah, message is clear that if possible, use the disposable ones and discard them with all precautions. Or if you are using a reusable one, follow all the strict protocols which are based on the hospital guided policy, that you use either quaternary ammonium compound or any other thing, and clean thoroughly, and then reuse the same thing for the other patients. Dr. Asim sir, can you tell about what is meant by barrier nursing, and where should we implement it and how to implement it?
Yeah, so barrier nursing is nothing but it is a set of intervention consisting of stringent infection control practices that is used during the nursing unit. And the main aim of this barrier nursing is that it is a protect of horizontal infection or horizontal transmission of infection from one baby to another. It is also protect the medical staff from the infection of the patient, and it is also prevent spread of infection to the outside of the units. Okay, usually the infection occur or spread in different ways, which include the contact with contaminated surface of hands, or fomites, or droplets, or inhaling aerosol. And this is mainly implemented in case of multi-drug resistant infection, where they are doing the cohorting system. Cohorting the neonate means that the neonate should be cohorted away from the rest of the neonate. There should be separate healthcare personnel for seeing this neonate, and there they should, in case of COVID situation, they can also see the appropriate PPE, and they also separate biomedical waste disposal, and that's where the barrier nursing can help for infection control.
Sure, sir. Thank you very much, sir, for emphasizing all the points. Dr. Anita, can you tell us about how to use this bundle approach? One thing Dr. Prashanta has shown us the CLAPSI bundle, both the maintenance and initial bundle. How to use these things and what is the concept behind it?
Yes, sir. So in case of neonatal ICU, the important infections which we would like to, and for which well-said bundles are there, are ventilator-associated pneumonia and the catheter-associated bloodstream infections. So VAP and CLAPI bundles are there. First of all, in the bundles, hand hygiene is there in both of them. So hand hygiene, alcohol-based hand rub should be there bedside, and it should be practiced whenever we have any of the 5 moments of hand hygiene. We must do the hand hygiene before approaching the baby. Then daily we should assess for the readiness to wean off from the ventilator. So whether the settings have come down, what the indication the child was on, it should be assessed whether the child needs to be continued to be intubated or can be extubated. And the circuit should be checked daily basis in every shift. If it's visibly soiled, then you should change the circuit. Otherwise, no need to routinely change the circuits every 24 hours. Periodically, we should be the condensate which accumulates within the circuit. It should be taken out and removed because that is a source of infection. Then for preterm babies and for neonates, the head end of the bed elevation is recommended 10 to 13 degrees. So that can be achieved by placing a sheet underneath the head of the bed, or some of the warmers, they have good head elevation 10 to 15 degrees. And asepsis, as we've seen in the video also, it should be maintained while doing the suction for these babies. Then oral care is to be provided with normal saline with care of the secretions. No chlorhexidine to be used for neonates. It's not recommended as in adults. So this is about the ventilator-associated pneumonia care bundle. For the Class B bundle, we start with hand hygiene. Then again, you should have the critical indication to put the central line, and there should be daily based assessment whether the line needs to be placed or we should remove it. So few of the many of the impact ICUs, they remove the line as soon as the enteral feeds are tolerated up to say 120 ml per kg, and because most common indication to put in is when we are not able to start feeds, and then we have to go with prolonged parenteral nutrition. So it should be removed and as early as possible by the time the baby reaches substantial feed, that is around 120 ml per kg. Then while insertion, as Dr. Prashant has nicely showed, the full barrier asepsis should be practiced. And there can be a checklist as shown in the video so that each of the steps know where it is breached and asepsis is followed. When the sister is or the nursing staff is going to handle the line, then they have to wear the same precautions, full barrier nursing, and they should scrub the hub with isopropyl alcohol swab 70% or 2% chlorhexidine. And for 30 seconds, allow it to dry, and then you should access the line. There should be regular periodic audits and checklists in place so we can have if the VAP rates or Class B rates are going up.
Thank you.
So these sets.
Yeah. Anything more you wanted to add? So, sorry, you wanted to say something?
Sir, I said these steps should be followed together as a bundle so that they can be effective.
Yeah. So that is the more important thing, that we have to follow all the steps together to prevent these infections spreading out or other things. Even if you use only one step in these bundle, it will not be effective. When you are using it together, then only it is the major thing. Okay. So like we used to see in the childhood when they used to show one stick you can break very easily, but if you keep all the sticks together and then you can't break it so easily when you bundle it. Okay.
And I think the key point would be to identify 3 to 5 evidence-based key interventions which you want to include in your bundle. It should not be too many, like if you include 8 to 10 interventions and you try to implement them all together, it may actually be discouraging in the beginning. So take 3 to 5 interventions, key interventions, take them as a bundle together and then try to practice it. And then you can improvise on that based on your unit improvements.
Yeah.
Yes.
Thank you for pointing out that, Pratima. Actually, so when you keep 20 at a time in a bundle, no one will follow it. Start using some 5, 6 which are more effective, and then start adding on upon based on your unit power, unit comfort. Can we move on to other question? Jyoti madam, you have been there as a nursing faculty for long. You might have seen a lot of issues in the when they introduced the biomedical waste management. Lot of steps have been taken by the government also to do the proper biomedical waste management. Can you highlight us why we need to do this?
Yeah, yes, sure, sir. Very good afternoon to all the panelists. And I really like to add that biomedical waste management is really needed as the training are going on very rigorous point of view from the government point of view. Like they want that the least minimum handling of the air pollution and the various pollution which is generated due to the hospital waste. And we need to identify where the lackings were. So importance, like if we are managing the waste properly, hospital waste properly, then it reduces serious health implications which occurs in a society, and it can prevent the outbreak of infectious disease. Like nowadays we are facing the COVID-19. If the management of this waste is not done properly, then again it is a real pandemic which can't be handled anymore. Like the people were spreading their mask here and there, they doesn't know where to discard in which bin it has to be discarded, even though they are just moving to have a look for the patients, and still they are not handling these things properly. So we need to know how to segregate the waste properly, and if we are handling the biomedical waste properly, it prevent the transmission of various diseases, not only the COVID-19, the separate other diseases are also, and it reduce the risk of waste which we can find from the scavengers or the waste handlers, those who are getting out with, from for their money, and so that they can earn their daily living. So we need to manage that hospital waste is to be segregated properly, as the in every unit, not only in ICUs, in every units of the hospital, they are charts were displayed that where the waste has to be handled, and there were biomedical waste nurses were there, those who are identifying do the people are segregating the waste properly. Even any single unit is not doing this, then they are giving them classes, and even they are having a checks on them that you have to do, because this is a really difficult problem for the whole, not for the hospital, not for the department. So I would like to know that we all know that yellow bins and the red color beans, white color bean, and the blue color beans we are having, and the separate bean is allocated for the separate type of waste in the hospital settings. So I think is this enough, sir, or I'll
Yeah,
have
I
to?
think you have highlighted, madam, all the points. So your first thing is that it will protect you and the community and the whole nation. So that's what we need to remember while you handle the biomedical waste management. So thank you, madam. I think most of us know what is when to use the red and when to use the yellow and when to use the black. But main thing is to emphasize that it has to be strictly followed at this thing, and segregation has to be done properly by all the people who are inside the hospital. Thank you, Shruti madam. Neeraj, we have only few minutes time, so I want all the panelists to give specific points. Neeraj, can you tell us about what are the risk factors for early onset sepsis and how it will guide for rationalizing your antibiotic use in your NIC?
Okay. So the common risk factors for early onset sepsis which we see is the presence of chorioamnitis in the mother, which means she has fever and there is some false Maillard discharge, there is some change in the heart rates. So the essential part is that mother is having fever with any of those things. Apart from that, if there is any premature rupture of membranes, which means the membranes have ruptured before the onset of labor, or if there is prolonged rupture of membranes, maybe duration beyond 18 to 24 hours, or the prolonged duration of labor. So all these are the common risk factors, and of course, the babies less than 1500 grammars or less than 32 week of babies. So if preterm babies or term babies are associated with these features, then they are at risk for early onset sepsis. And it is important to understand these reasons, because if we know that a baby after birth, especially the preterm, is symptomatic, and there is some any of these risk factors is present, then the chances of having infection is pretty high. And then we do start antibiotics after taking blood cultures. We look at the clinical course and take a call based on the clinical course and based on the culture reports that how the child is behaving. As of now, occasionally it may happen that we may get some culture positivity from the mothers. That may help in deciding the kind of antibiotic, but usually the correlation is not good. So in general, whatever our antibiotic policy is for early onset sepsis, that remains irrespective of the kind of organisms which we are able to isolate from the mothers, especially from the high vaginal swabs.
So it will regulate your antibiotic policy, and also you can rationalize and restrict the antibiotic usage based on the risk factors model. I think risk factor model is there in your module that is based on the prolonged rupture of membrane, gender, and other things, 6 factors which are there. I think people can go through it for usage in your units. Asim sir, I think this is close to your heart, this topic. So how do you say that KMC and improving the breast milk usage will help in preventing infection?
Oh, yeah, it's a good questions and good topics. And you see that the KMC is the most important evidence-based practice that can reduce not only the neonatal mortality, there is also morbidity. And the main question is that how KMC will prevent infection. You see that evidence-based study shows that there is definitely by doing KMC, there is a severe infection is reduced. And you see that if you do KMC, it is the minimum handling by the parents and mothers, and also the minimum handling by the outsider also. And if you do the KMC, one of the component is that the baby will take the breast milk, and by doing KMC, there is improvement of breast milk. And we all know that the breast milk is rich in bioactive products, factors, which is a boost immunity. There is a secretory IgA that prevents entry of bacteria in gut. There is a lysozyme and lactoferrin, that's also antibacterial, antifungal, and antiviral property. And not only that, there is oligosaccharide that prevents bacteria attached to mucosa. And also, if you do that, the breast milk, use of breast milk, that also prevent COVID-19 also. So that's why the KMC is the main way of preventing the infection, mortality, even the COVID situation. COVID. Okay.
Thank you, sir, for emphasizing the things. So, as somebody, I think, Baby Mandal Madam and Paralatta Madam was emphasizing initially that they used to train the mothers. So, this is one of the interventions from the mother that can prevent the infection in your NICUs. And also, nowadays, we have made it mandatory in our unit also that before you write any prescription, first thing that we will emphasize is that get the colostrum from the mother as early as possible. So this is the instruction that we are giving to the nurse right now, and that is actually helping us to improve the breast milk use in our unit. Dr. Anita, can you enlighten the nurses who are here about aseptic non-touch technique?
Yes, sir. Thank you, Dr. Tejo. A wonderful question. So I think there has been some discussion on this on the Telegram app also. So asepsis non-touch technique follows 4 principles. You must always wash your hands properly and never contaminate the key part. Key part is part of the equipment which should not touch anywhere else except for the side where it's going. And then identify the key site. Key site is the area on the patient which must be protected. So suppose if we are putting an IV cannula, so the needle tip of the cannula becomes the key part, and the area, the vein where we're going to insert on the skin becomes the key site. So we should attempt not to touch the key part and the key site directly with our hand, either gloved or non-gloved. We should not touch these 2 areas. Rest of the non-key part, suppose we hold the cannula, the backside of the cannula becomes the non-key part, that should be handled confidently. And once the aseptic site is prepared or the skin is prepared, we should not be touching the key part or the key site directly. Just hold from the non-key area of the instrument and insert it in the body.
Thank you, Dr. Anita. So the key point is that you should not touch the insertion site or whichever is your procedure main point, so that the infection will not spread into the body. Jyoti Madam, once again, one more question for you. That is, can you enlighten us about some key components? Somebody wants to start antibiotic stewardship in their hospital. What should be the key components?
Yes, thank you, sir, for the question. And I really like that this question, as we have discussed very lot, that antibiotic not to be started as early as possible. It is to be started when there is an actual need and we got the result of culture positives and we find, yes, the baby having not single factor which is related to the systemic infection, but more than 2 factors we are having. And like in every hospitals, in SNCUs and ICUs, we are having a written policies when to start antibiotics, and like the when we are finding the baby is showing some symptoms, first we have to send a sample for the culture so that we can know there is a requirement of antibiotic. If we are finding the reports were positive, then we can go with the first line of antibiotics, that can be ampicillin or gentamicin we can start with. And if we need it, and we need to document when the drug and dose and the frequency has started, like it is to be started and for how long it is to be given, it has to be mentioned in the prescription of the baby's file, and even with the every radiant warmer, so that every staff of the shift, they are aware that baby is already on the antibiotic therapy and since how long and when it is to be need to be changed. Like sometimes we are finding the baby is not responding to the antibiotic therapies, then there is need to send the samples again and check it out, there is a need to move to the second line. And all of us to focus that excessive use of antibiotic can lead to a very big complication in our newborns and the neonates, like it can be an NEC, that is necrotizing candidiasis, and the death to the babies. So we have to be taken care that excessive use of antibiotics not to be prevalent, it is to be stopped whenever is required, only then the antibiotic has to be given. So I think this is.
Yeah, so the key components is same. So we should have the written policy, one thing antibiotics, and for each type of infection, how many days we have to give. Second thing, we should have the hierarchy of antibiotics, which can be prescribed by whom, and then second line, you have to take the permission from whom, and third line, where to take it, and then you should have one infection control team in your own unit where that can review the high-end antibiotic usage in your unit and also look at the aseptic precautions that are getting done. And all these policies should be based on the cultures in your local area, and you can go ahead. There are a lot of mnemonics for the antibiotic stewardship. Because of time, I think I'm not going into all the things. Few questions in the chat box. I think anyone can take it. I think we have 10 people here. One is that many of the times that queries are that when I started using IV set or oxygen flow meter, for how many days we need to, can I use it? Shashikant sir, can you take this question? Shashikant sir, unmute sir, unmute sir. Not able to hear. We are not able to hear sir. We are not able to hear sir.
I think we can give to someone.
Yeah, I think. Yeah, that Neeraj, you want to tell?
Neeraj, yeah.
So, question is that for how long we can use this? So, if you look at the evidence for using or change of IV sets, your PMO lines, your syringes. So, the evidence actually suggests that you can use these things for 72 hours, except if you have used this set to deliver lipids or any kind of blood product. If you have used lipid, then you have to discard that within 24 hours, means maximum 24 hours. If you are using it for blood product, then of course it has to be changed and you are transferring it, then you need to use the separate one. For clean fluids which we are giving, whether it is aminoven or any kind of dextrose solutions, isopride P, there you can safely use it for 72 hours. In our unit, in fact, we use it for 48 to 72 hours and change after that. So that was a question, Dr. Tejo?
Yeah, the same thing. I think that was what people are asking. Mayank, are you there? There is one query regarding UVC catheter flush. So which has to be used? Is it the Heplock or heparin whole solution? Mayank, are you there?
Sir, can you repeat the question, sir?
There is a query from one of the nurse who is attending. When you are flushing the UVC catheter while you are inserting, do we need to use the Heplock or do we need to use the heparin whole heparin solution?
So during the first insertion, we use the Heplock solution, sir. However, we do not use regularly the Hepsaline solution for flushing. In fact, the Heplock solution also has to be diluted first. We do not use the concentrated one, that 10 unit per ml. So we first dilute it 10 times to 1 unit per ml, and then we use it for flushing. But in regular use for further, if we need to further flush in between, we use normal saline.
Sure. So least dilution possible, 1 unit per ml. That's what we need to use it, so that there will not be any errors in the heparin usage or this thing. There is a question on suction jars maintenance. I think Baby Mandal madam and Parulata madam can answer this. Do we need to keep the suction jars dry, or you want to keep
Pre-filled with water?
Pre-filled with water.
Suction jar should be not. It should not be dry. It should be it's after cleaning, when first time we are attaching the suction jar, that is suction container, we have to pour 0.5% hypochlorite solution or 1%. We are pouring here in our unit 1% hypochlorite solution. We are placing 1% hypochlorite solution, minimum amount approximately 50 ml in the beginning, just in the upper mark. 50 ml, 1% hypochlorite solution.
Sure. Neeraj, you want to add anything?
Thank you.
I think ma'am has rightly pointed out. So yeah, suction jars cannot be dry because all the secretions will get collected. As soon as those secretions goes into the jar, it has to be disinfected. It has to be, so there has to be some hypochlorite solution, as already highlighted, 0.5 or 1%. And then it has to be cleaned regularly, as already been pointed.
Thank you.
Yes.
Prashant, are you there?
We are cleaning in every 24 hours. We are changing suction jars every 24 hours. And then after we are washing thoroughly with soap and water, drying, then immersing in 2% glutaraldehyde for minimum 20 minutes for disinfection and minimum 10 hours as recommended by the manufacturers, minimum 10 hours for sterilization. And then again we are using and we are pouring 1% hypochlorite around 50 ml.
Thank you. Thank you. Yes. Prashanta, one question. Can we use the heat moisture exchanger or closer suction catheter while the baby is ventilated? Prashant, are you there?
Yes, sir. Sir, my network is not that stable. Am I audible, sir?
Yeah, you are audible, Prashant.
Yeah. So just to answer the question, I don't think that is recommended in newborns. I'm not aware of any studies which have done the feasibility. Although, I mean, a decade back when we happened to use it, so we would find it more cumbersome. Other thing is there were more carbon dioxide retention in these babies. So as of my knowledge, it is not recommended for newborn babies. So no.
Regarding HMB filter? Heat moisture exchanger filter.
No, sir. No. It should not be used in newborn babies.
So when we are using the humidified air, so HMB doesn't have any role in terms of routinely using, but HMB now people are using it in the extubatory limb to, especially in the COVID pandemic, where it can filter the secretions and keep it there so that the machine will not get contaminated. And closer suction catheter, as Prashant was highlighting, that not for the routine use. Some people sparingly are using it when there is a high settings and the high frequency oscillatory ventilation, when you don't want to disturb the baby too much for this just suctioning purpose. So those are the things that we can highlight. Shashikant sir, are you ready?
Am I audible now, sir?
Yeah, now audible, sir. There is one interesting question for you, and then you can start off the summarizing the total session. There is a question that is there any scientific principle behind wearing the right hand gloves at first?
No, there is no scientific principle. It depends on person to person. It depends upon the handedness of the person itself. So I have seen persons who have been using left-handed gloves first, and some persons who have been using right-handed. So there is no scientific principle. It depends upon the person's usage.
Dominant hand should be worn first to avoid any.
Yeah.
I mean, you decrease the risk of contamination because this
That's
is
the only thing. Yeah.
likely to use more. Yeah. So that is why you should be in that.
Hope we have taken all the questions, Pratima. I think we have taken all the questions. Yeah. I request Dr. Shashikant sir to summarize the session, and then I will hand over to Dr. Pratima.
Thank you, Dr. Tejo, for this opportunity. So we all would agree that neonatal sepsis is one of the most important preventable cause of mortality. This incidence is even more in low middle income countries. So therefore, the topic of asepsis was very, very pertinent, and I am happy to see that all the topics and important components have been very beautifully taken up by all the delegators. So this week started with the pinning of the resources. These were standard excellent resources, easily understandable by the nurses. So it commonly covered all the possible sources of infection, the harms that sepsis can do, the skin and cord care, the bundle care approach, the role of feedings, and the KMC to start with. So in the initial phase, it was beautifully explained by Dr. Neeraj and Parul ma'am, the importance of prevention of the neonatal sepsis by activating the appropriate areas and the ways to decrease the sepsis. They also discussed the innovative ways by which the sepsis could be prevented. They beautifully described that the source of infection was not only in the NICU itself, even the areas which are commonly neglected, such as the labor room, where the babies are born, should be actively taken care of for prevention of sepsis. And not only that, they also explained that the postnatal interventions, which are commonly used, are also very important risk of sepsis introduction in the babies. So therefore, that is also important to take care of. It was described by none other than the participants the very best practices for the prevention of the sepsis. Then the bundle care approach, as well as the cluster care method of tackling and the caring of newborn, was excellently explained by the facilitators and also by the participants. Then routine equipment cleaning and the prevention of infection was established to be the most basic during the this approach. Then in the next session, it was also described that what are the 5 moments of hand hygiene, and the steps of the hand hygiene were also described in details. The skin care, the cord care, the aseptic non-touch technique, the washing steps, and the fumigation required or not required, and the use of diapers, etc., was also taken in the next sessions. Last but not the least, then came the clinical part. The sepsis was also addressed, although in less detail, that what is the definition of sepsis, what are the different types of sepsis, what are the risk factors for sepsis, what are the symptoms of sepsis, what are the precautions during the antibiotic prescription, what is antibiotic stewardship. Then after that, there many quizzes were put by our eminent members. I must say, and I must congratulate the participants, that we received more than 1,000 responses from them, and a few of the participants like Shakila ji, Vincent, Shalu, Fatima, they all were very active and they were very ready to answer. So it is the best part. It is very heartening to see that the sisters themselves, they're very interested in such kind of discussion. I'm sure that it would have been gone a long way. It would have helped them. And in today's session, also we had a very good live session, live demonstration of by Parul ma'am, Asim sir, Prashant sir, and we also described the live suction techniques, then the cleaning of the bamboo mask, cleaning of the laryngoscope was also described, and how to do various other things. But also the checklist was beautifully explained by Prashant sir and Devi Dayal and the Deepa. It was very good. So summarily, it was we all would agree that the sepsis is very important preventable cause. So in nutshell, what are the various things by which we can prevent this introduction of sepsis? Because it is difficult to treat sepsis once it sets in, and even late onset sepsis is also even more difficult and also associated with a lot of mortalities and morbidities. So coming to summary of this, the hand hygiene, the 5 moments of hand hygiene especially, and the steps of the hand hygiene done in adequate time, adequate hand rub technique is important. Then we should all take care that sepsis does not seeps in the labor room, at the entry to the NICU, in the NICU babies, and doing various procedures using aseptic non-touch techniques. We should also remember that breast milk introduction and feeding only breast milk is one of the wonderful methods which should always be tried as soon as possible and as maximally as possible to prevent the introduction of sepsis. Then KMC was also also an important technique of decreasing the sepsis. And we should also give antibiotics using the antibiotic stewardship. They should be given for shortest duration, least possible time, least as per the all the principles of antibiotic stewardship. They should be given. Not only antibiotics, the IV fluids also should be given for the least possible time. We should always incorporate aseptic non-touch technique in our day-to-day practice, and strict asepsis during all the procedures like blood sampling, IV line handling, then changing of fluids, scrub the hub, CLAPSI bundles, VAP bundles, they all should be practiced. Last but not the least, the skin care and the cord care also important components of this prevention of sepsis. So with this and all other factors, they have been beautifully covered in this panel discussion, and with all my friends and facilitators, I must congratulate the team, especially Devarari sir and Aditi ma'am for inviting us for this important topic. Thank you, ma'am. So this was all the summary of this beautiful week, having more than 1,000 responses, and I must congratulate all the participants also who have wonderfully participated in this. Thank you.
Thanks.
Anything, Pratima? Yeah, Pratima, before you close, one thing I just remember Dr. Baku's lectures on infection, if you see, he says that you have to follow the path of the organism. So if you follow that organism, how from where it will come and where it will go, then all the aseptic precautions will come into your mind and you start doing the right things at right place. Okay. So with this, I think, shall we close, Pratima?
Yeah, on behalf, thank you everyone. I think it's 2 o'clock on Saturday. On behalf of Devarari sir and the whole Preterm package team, thank you all esteemed faculty members. And we always wish that we have blessings and wishings from you, Parul ma'am, Asim sir, Neeraj sir, Tejo sir, Shashikant sir, and our nursing colleagues, Jyoti, Percy, my friend Anita, Prashant, who always actually supports in all the endeavors. Thank you so much. Thank you, Tejo sir. Thank you, Asim sir, Neeraj sir, for taking out time. Just for the participants, please complete the assessment of the week. It's mandatory for the credit hour certificate, and it will be open till tomorrow night. Monday, we'll be starting a new module. And thank you so much for joining in. Have a nice weekend. Thank you, Parul ma'am, Mandal ma'am. Thank you. Nice to see you.
Thank you.
Thank you.
Thank you.
Thank you, sir.
Thank you, everybody.
Thank you.
Thank you for participants.
Thank you. Bye-bye.
Thank you, ma'am.
Thank you.